Alrighty. I hope everybody is having a great morning, a great afternoon, depending on where you are in the world. Today, we're going to be discussing medical complications of eating disorders with Chrissy Stockert. Chrissy is the Director of Health Services and Quality Assurance at Within Health. She's a registered nurse who has been working in the field of eating disorders for the past 10 years. She has a passion for helping clients fight against their eating disorder voice so they can find true and lasting recovery. In addition to caring for clients directly, Chrissy also spearheads the compliance efforts of Within Health, including state licensing and Joint Commission accreditation. Chrissy, thank you so much for being here with us today. We're so excited to have you at Within Summit.
Thank you so much for having me. So I'm glad that everybody is here and that I get to talk today a little bit about medical complications of eating disorders. As a nurse, this is something that I feel very passionate about. And I think one of the things that's important to talk about is why we have to care so much about this. So a couple of reasons. One, eating disorders come in all shapes and sizes. So a couple of statistics, only 6% of people with eating disorders are medically diagnosed as underweight. 9% of the US population, or 28.8 million Americans, will have an eating disorder in their lifetime. So pretty huge number. And 3 out of 4 women in the United States have disordered eating. So a lot of people will say, oh, I've never known somebody with an eating disorder. And the reality is, yes, you have. You may not have known it, but you do know somebody who has an eating disorder. We also have to care because eating disorders at this point are starting so young. So by age 6, girls especially start to express concerns about their own weight or shape. 40 to 60% of elementary school aged girls, 6 to 12, are concerned about their weight or about becoming fat. And this concern endures throughout their life. 81% of 10-year-olds are afraid of being fat. 51% of 9 and 10-year-olds feel better about themselves if they are on a diet. That is 9 and 10-year-old kids. And according to a recent study, over half of the females between the ages of 18 and 25 would prefer to be run over by a truck than be fat. And 2/3 surveyed would rather be mean or stupid. I also think that we need to care so much, and this is what we're going to get into for the rest of our time together, because eating disorders are deadly. Eating disorders are among the deadliest mental illness, second only to the opioid overdose epidemic that we have right now. At least every 62 minutes, someone dies as a direct result from an eating disorder. So in the time that we are going to be meeting here today, somebody will likely die as a direct result of their eating disorder. 20% of people suffering from anorexia will prematurely die from complications related to their eating disorder, including suicide and heart problems. Eating disorders are severe, and they affect every single body system that we have. So today, what we're going to do is we're going to take a look at some of the most common medical complications that we see in our treatment setting. And a couple of things to remember as we're going through this is energy in equals energy out. So a lot of what happens to the body is a direct result of not enough energy coming in, or that energy not coming in consistently. And so the body systems start to shut down so that the energy out can compensate for the lack of energy coming in. A couple of other things to remember: the majority of medical complications related to eating disorders are universal to eating disorders. There are a few that are more tied to one diagnosis versus another, but in general, when we're talking about eating disorders, there is starvation involved, there is a lack of energy intake coming in. And so whether it's somebody who has a diagnosis of anorexia, bulimia, binge eating disorder, or any of the other diagnoses that we have surrounding eating disorders, these complications are universal. And lastly, there are a lot of things that I'll talk about that are going to lead to one complication, another, or death. And so it's also always important to remember that the body is incredible, and that with very few exceptions, it can also be fully restored. So we can go ahead and jump right in. So the first thing that we can talk about is the blood. So there are changes that we see when we're talking about lab values. One of the things to know is that the blood always wants to stay stable, and it's going to do anything that it can to keep its balance throughout the course of an eating disorder. So once labs become abnormal, that's a big problem. A lot of clients will come in and they'll say, but my labs are totally normal. And I'll say, well, that's a wonderful thing. They're going to be fine, 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 fine until all of a sudden they're not fine. And when they're not fine, they're really not fine. So we'll talk about a couple of specifics around the blood. So one of the things that we can look at is we can look at sodium. When we go and we have our clients get their blood drawn, one of the things that we're going to check is their electrolytes. So sodium is one of those. We talk about sodium being normal. A normal sodium is somewhere between 135 and 145 milliequivalents per liter. And a sodium that's too high or too low can be dangerous. We can talk about things like headache, confusion, loss of energy, drowsiness, and fatigue, muscle weakness, spasms and cramps, seizures, coma, and ultimately it can lead to death. When we are talking about eating disorders, we often see something called hyponatremia. So hypo meaning low, natremia meaning salt. And we see this because of a behavior called water loading. So when somebody does not have an eating disorder and their kidneys are functioning totally normally and properly, we can filter out all of the water that we drink in a day with no real issues associated with it. When someone has an eating disorder and their kidneys have in some way been compromised, whether that's by kidney function decreasing or other hormones in the body telling the body to retain fluid, which happens very often, when somebody drinks a large amount of water, and it can be for a variety of reasons, essentially what can end up happening is you can dilute the blood. So it would be very hard to eat so much salt that you are going to raise your sodium level. But sodium is very affected by the volume of fluid that we have also. So if I were to take a teaspoon of salt and pour it into a cup of water, I would have some pretty salty water. If I were to add a lot more water to it, that sodium would become much more diluted. And so that's what can happen when someone engages in overhydration as an eating disorder behavior. They dilute their blood so much that their sodium level drops, and it can become very dangerous to the point that we've seen people who end up having seizures go into a coma. And again, it can end up ultimately leading to death. The good news is that if the behavior stops and the sodium normalizes, if it was strictly eating disorder related, you won't see it happen again. So once normalized, it's going to stay that way unless you see that behavior kick up again. Another example of an electrolyte that we check frequently is potassium. So again, potassium too high or too low can be extremely dangerous. It can lead to fatigue, muscle weakness, spasms, tingling, heart palpitations, and most dangerous, it can lead to cardiac arrhythmias and death. Potassium is, an imbalance in potassium is something that is more tightly related to purging behaviors than it is to other eating disorder behaviors. So if you remember that one of the things I said is most of these things are universal to all eating disorders. Potassium is one in particular that is very tied to purging, but it can be purging via any means, purging via vomiting, purging via laxatives, purging via diet pills or diuretics. All of those can remove potassium from the body, leading to typically what we see is hypokalemia, so low potassium levels. Very often, it's not something that you are going to be able to sense in your body ahead of time. It's something that will become abnormal quickly and can lead to complications very quickly. So if we see a potassium level that's abnormal, we want to get it corrected right away. Glucose is another one that we see that's affected very often in eating disorders. And this is one that I like to take a little bit of time to explain because it can be affected by eating disorders in various ways. So a typical course of action for glucose is that somebody would eat something, somebody without an eating disorder would eat something that food and that glucose would be absorbed into the bloodstream. Once it's absorbed into the bloodstream, that triggers the pancreas to say, there's glucose in my blood now, and it releases insulin. And insulin is what allows sugar and glucose to go from the bloodstream into the cells, which is where it actually does its job. When someone has an eating disorder, though, their body is depleted of glucose to begin with. So glucose, where it should normally be somewhere between 70 and 100 when somebody is fasting, meaning they have not been eating for a long time, somebody who has an eating disorder may have asymptomatic hypoglycemia, meaning low blood glucose, and they have no idea that it's happening. When someone has symptomatic hypoglycemia, they're going to feel really, really awful. It can cause things like all of a sudden you have a terrible headache. You feel very shaky. You may get a cold sweat. Anxiety can kick up. And there's something that's often referred to as an impending sense of doom, because hypoglycemia can lead to coma and death. And in someone without an eating disorder, it's going to be a huge trigger to say, I need to eat something right now. But in someone with asymptomatic hypoglycemia, like we often see in an eating disorder, they're not going to feel those symptoms, and they could end up slipping into a coma. And there have been cases now where we're seeing that people are dying from hypoglycemia. Now, there's another way that glucose metabolism can be affected when somebody has an eating disorder, and that's at the beginning of the recovery process. So another phenomenon that happens with eating disorders is with the reintroduction of food, we often see something that's referred to as postprandial hypoglycemia. So post meaning after, prandial meaning eating, hypo, low, glycemia, sugar. And so here's what ends up happening. I told you what happens normally. We eat something, that glucose is absorbed, the insulin gets released, and into our cells it goes. When someone starts to eat again, who has an eating disorder and has been malnourished, the body kind of forgets how to function properly. So somebody would eat something, that glucose gets absorbed, the body says, thank you for feeding me, dumps out a ton of insulin, and all of the sugar goes flying into the cells immediately, and the level of glucose in the bloodstream starts to crash, which leads to all of those symptoms of hypoglycemia. So somebody will come to me and say, I just ate, I feel terrible right now. And we can talk about why that hypoglycemia is happening. Now, when somebody doesn't have an eating disorder, they have storages of sugar throughout their body, mainly in their liver. So if my body were to experience some hypoglycemia, my pancreas would release another hormone called glucagon, which would tell my liver, release the stores of sugar. My blood glucose level would come right back up to normal, and I would keep walking and talking without ever knowing that anything had happened. Someone with an eating disorder does not have those stores of sugar, though. So their body will release the glucagon, which will tell their liver, release those stores of sugar, and absolutely nothing happens, because they don't have those stores of sugar to help replace what may have been lost in the bloodstream. And it can end up feeling very, very bad. So we tell them, you need to eat something with sugar, maybe pair it with a protein so that the glucose can be metabolized quickly, and then the protein can carry that through to your next meal or snack. It's a very uncomfortable feeling, but it's something that we can navigate in the treatment process. Another lab value that we often check is something called phosphorus. So phosphorus is, I'm going to ask a lot of you to go back in time to the days when you were in biology and chemistry and think about ATP. Look, most people have their camera off, but has anybody heard of ATP, that little energy packet in the body? Ah, yes, I see a hand that went up. Okay, so the P at the end of ATP is phosphorus. And phosphorus, if you want to think about it as the energy packets in the body. And I remember it so clearly from a nursing book that I had, where it acts like a hook. So phosphorus is that P at the end of ATP. It's a hook, and it causes effective muscle contraction. When someone has an eating disorder, their body is naturally over time depleted of phosphorus, because if energy in is low, energy out is low, phosphorus is not needed as much, and those natural amounts of phosphorus in the body get lower and lower and lower. But phosphorus is needed for that effective muscle contraction. So one of the things that was actually discovered after the Holocaust was when prisoners of war and concentration camp survivors were released. They did not have eating disorders. They were given all of the food that they wanted, and then some of them died. I was like, hang on a second, what just happened? So a tremendous amount of research was poured into it, and it was discovered that phosphorus was the key element in this process. So when somebody's body had been depleted of phosphorus, and then they began to eat again, the body needed extra phosphorus in order to be able to create all of the ATP that it wanted. And if it didn't have enough of it, it would start stealing it from different places in the body. And one of the places that it would steal it from was that muscle that needs to contract tens of thousands of times a day, the heart. So when that phosphorus was stolen from the heart, it ended up causing ineffective muscle contraction, which can also be called congestive heart failure, and it led to death, and it happened very quickly. So what we can do with that is we can replace phosphorus with a supplement. We don't ever want somebody's phosphorus level to even dip into that low range. So rather than saying, let's wait for it to get low, we're going to replace that phosphorus before we even see it get into that low range. So those are just some of the lab values that we can see become abnormal when somebody has an eating disorder or is at the beginning stages of that recovery process. Another organ system that is affected by eating disorders is the heart and the cardiovascular system. So like I mentioned before, when we were talking about phosphorus, the heart needs to beat tens of thousands of times a day, and that takes a tremendous amount of energy. If somebody has an eating disorder and they are not giving their body enough energy, that cardiovascular system is going to change in order to help compensate for the lack of intake of energy. So one of the things that we will see very often is we see something called bradycardia. So a normal heart rate when somebody is resting, meaning they are not doing anything for about 10 minutes, is somewhere between 60 and 100. When a heart is starved, it wants to beat less often because it wants to conserve energy. So very often what we will see in eating disorders is a low heart rate, a resting heart rate below 60 beats per minute, in order for the body to say, now I don't have to expend as much energy. One of the problems with this, though, is that there is another thing that can cause a low heart rate, and that is somebody who engages in a lot of exercise and is very athletic. So very often, somebody with an eating disorder also engages in a lot of movement. So if they go to the doctor and they have a resting heart rate somewhere in the 50s, it is very often reinforced that this is a great thing. Congratulations, you're an athlete. But there's a very big difference between an athletic heart and a starved heart. An athletic heart is saying, I am so efficient that I don't have to beat as often to fully oxygenate my body and to make sure that everything is running at top quality. And a starved heart is saying, how little do I have to beat to keep you alive? And so one of the things that we often want to do is we want to reinforce in the medical community that with an eating disorder, we don't want to see a low heart rate, and we want to see that actually come back to normal, to somewhere in that 60 to 100 beats per minute, to say, now your heart is starting to say, thank you, I can beat enough. Another thing that we often see with eating disorders is something called orthostatic hypotension. So most people know when they go to the doctor, they're going to get their blood pressure checked. And there are two numbers. There's the top number and the bottom number. So our top number is the systolic blood pressure. The bottom number is the diastolic blood pressure. The top number, that systolic blood pressure, is the amount of pressure it takes to eject blood from your heart. And the diastolic, or that bottom number, is the pressure of our heart when it's at rest. So when we are talking about orthostatic hypotension, we're talking about one of two things that can happen, or a combination. It is either a drop in that systolic blood pressure when somebody goes from sitting to standing, and or an increase in their heart rate when they go from sitting to standing. And it can be any kind of posture change, lying to sitting, sitting to standing, but basically anytime you change positions, your body wants to be able to keep its pressure, because if I stand up quickly, gravity takes over. If gravity takes over, blood will fall. And if blood falls, it's not going to get here to my head where I actually need it to get to my brain. And so my body, when I stand up, is able to immediately whoosh, change my blood pressure to keep that blood going upwards to my brain. When someone has an eating disorder, though, the body cannot compensate quickly. And so what you often see is that drop in blood pressure, which is going to make somebody feel extremely dizzy. And you've all probably felt it before when you go from sitting to standing, or maybe you were squatting on the ground and you stand up and you're like, whoa, I just stood up way too fast. And you get that sense that, whoa, that head rush, maybe it gets black, or you see a couple of little stars, and then it gets better. The problem, though, is that with eating disorders, that doesn't happen occasionally, when I stand up. It happens every single time I stand up. And it can take minutes for that feeling to go away, and not seconds for it to go away, which can lead to an increased risk of falls, hitting your head, all kinds of things, and generally feeling really, really bad. You don't feel good when your blood pressure is too low. But again, all of it is a way to compensate for not enough energy in. If blood pressure is lower, it's not going to get to the extremities the same way that it would if our pressure was higher. So it's going to keep everything here in this vital organ area of our body. By simply lowering that pressure, the blood is going to stay in our central organ system, saying, you know what, my heart, my liver, my lungs, my spleen, those are all more important than, fingernail growth. So one of the ways that we can look at that is by looking to see if somebody has what's called acrocyanosis. So acrocyanosis, if anybody here is a parent, when they were in the hospital with their newborn, they probably were told about an APGAR score. And an APGAR score is, how is that newborn doing at 1 minute of life or 5 minutes of life? And the A of APGAR is acrocyanosis. It's a totally normal thing in an infant when you see that their feet or their hands are this really, really deep red, like I have here in the picture. Past infancy, this is not a normal thing. But with eating disorders, we see it all the time. And the way that you can look at it is, and everybody can do this with me right now, if you take a look at either your fingernails or the pads of your fingers, it's kind of a pinky normal color for you. If you press down on it, it should lose its color. And then when you let go, that color should come back. And that's called capillary refill. So what you've done is you have manually pushed all of the blood out of the capillaries and into your veins. And we want to see how long does it take for those capillaries to refill with blood so that we know that circulation is working well. If capillary refill is very slow, your finger is going to stay white for a very long time. And you may notice pooling of blood, which is what's going to cause that very deep red or purple in the extremities. So normal capillary refill is anywhere between 1 and 3 seconds, or basically less than 3 seconds is what you want to see for capillary refill. When we see people with eating disorders, though, we often see that capillary refill is 6, 8, 10, 12 seconds long. Their body is not circulating their blood effectively, but it was a natural compensation for the lack of energy being taken in. So those are a couple of the cardiovascular changes that we can see, and we'll have time for questions at the end. So if you do have any questions, you can put them in the chat. So the next system that we can look at is the GI system. With the GI system, what we see is that everything slows down. So in a state of malnourishment, the GI system wants to hold on to everything for as long as it can. And this can lead to a host of problems from top to bottom. So if we were to start at the top, one of the things that we often see with eating disorders is acid reflux. So when I eat something, it's going to go from my mouth into my esophagus and down into my stomach. And between my esophagus and my stomach, there is a sphincter called the esophageal sphincter. And that should be very, very tightly sealed, because the stomach, in order to help us digest, produces hydrochloric acid. If that seal is not super tight, and that can happen for a variety of reasons. There are people without eating disorders who experience a lot of acid reflux, but we see it in eating disorders because of weakness, or we see it often when somebody engages in purging via vomiting, because if food is constantly going up and down, that sphincter loosens. And if that sphincter loosens, it essentially creates a free flow of acid up and down the esophagus. This can lead to inflammation in the esophagus, which can lead to ulcers. It can lead to narrowing of the esophagus from scar tissue buildup. And it can lead to something called Barrett's esophagus, which is a precancerous change to the esophageal lining that can lead to esophageal cancer. There are treatments for it. Sometimes it's something like good old-fashioned Tums. Other times it can be something that somebody needs to take on a daily basis. And where I said that most things are reversible when we talk about recovery from an eating disorder, this is one that can last longer. There are times where if that sphincter has loosened enough, it's not going to tighten back up, and acid reflux is something that somebody may deal with for many years. Other times it does resolve with recovery from the eating disorder. Another thing that we see is gastroparesis. So gastro meaning that GI system, paresis meaning stopping. So an extreme slowing of that GI system. And if you think about why that might happen, it seems like a very natural occurrence. If somebody is not nourishing themselves properly, the body wants to hold on to anything that it's being given for as long as possible. So that GI system is going to slow down tremendously in order for anything that's there to be given as much time as possible to be absorbed into the body. But it can be extremely uncomfortable. It can lead to things like nausea, vomiting, abdominal bloating, pain, eating a few bites and then feeling feeling full right away, acid reflux, changes in blood sugar level. So there are a host of things that can happen with gastroparesis, and the treatment for it, keep on eating. There are other things that can be done in order to help soothe some of those symptoms, but at the end of the day, it's nourishment that's going to help it. The problem is it doesn't happen immediately. So somebody will start to eat and will think, well, I'd like my GI system to start working perfectly again today. And our GI system may have other thoughts. And so it can take a while for the GI system to really fully restore itself and start to move consistently, which can lead to another common thing that we see with eating disorders, which is constipation. So constipation, meaning any kind of decrease in bowel movement frequency to anything less than 3 times a week. When somebody has an eating disorder, things are very often very tied to the GI system. And there is very often a feeling of wanting to feel empty. So it's a fine balance when we're talking about recovery from an eating disorder between, is this really constipation or is this you wanting to feel empty? And so as part of the recovery process, we really work through that. But constipation is a very real complication that we see with eating disorders. And there are times where someone will come to us and say, I haven't had a bowel movement in 7 days or 10 days. And I just say, oi, could you imagine? And then the problem that comes with that is that our large intestine has basically one job to do. It's to absorb water. So if somebody's GI system is moving slowly and water is being absorbed from the colon, the stool that's there is going to get harder and harder, which means it's going to hurt more and more when it actually needs to pass. So it can lead to all kinds of things like hemorrhoids, fissures, fecal impaction, rectal prolapse. All kinds of things can happen because of constipation. But one of the things that we do not do is we do not recommend that someone take a stimulant laxative. If we are going to recommend that somebody take a laxative, we're going to recommend an osmotic laxative, something like Miralax. An osmotic laxative draws water into the colon to create bulk, and that bulk is what helps to contract the intestines to allow the stool to keep moving. A stimulant laxative works on the nerve endings in the colon. It forces muscle contraction, and there can be very long-term consequences to stimulant laxative use because they can be very easily abused. So what we will often see is that someone will come into treatment needing to take sometimes up to 100 to 200 laxatives a day in order to have a bowel movement. And it can eventually lead to burning out the colon so that those nerves will never work again. And there are cases of people needing colostomies in order to have a bowel movement. And if you're not familiar with what a colostomy is, it's basically a bag that is attached to your large intestine that you would then have bowel movements into because your intestines will not create that contraction to have a bowel movement through the normal route. So those are some of the GI complications that we see. The other things that we often see are endocrine system changes. So there are a lot of different ways that hormones can be affected by eating disorders. And in a state of malnourishment, the endocrine system, like every system in our body, is going to help adapt to allow us to survive. So one of the things that we see very commonly is something called euthyroid sick syndrome. And what that means, it's a fancy way of saying the thyroid looks sick, but it's actually not sick. So in a normal functioning thyroid, there are a lot of different systems at play. In our brain, we release a hormone called TSH, thyroid stimulating hormone. And that tells our thyroid, hey, thyroid, release hormone. And that hormone that's released, and we often refer to it as T3 and T4, are the hormones that drive the metabolism in our body. If someone has hyperthyroidism, meaning their thyroid is in overdrive, you would see high levels of T3 and T4 because it's in overdrive. And you would see low levels of TSH because the brain is not going to tell the thyroid to be stimulated right now. It's going to be like, whoa, back off. I don't need so much hormone right now. Stop stimulating itself. But we still see those high levels of T3 and T4. On the opposite side, if somebody has hypothyroidism, which means that it's low and not functioning well, we would see low levels of T3 and or T4. And you would see high levels of TSH because the brain is going to be like, hey, thyroid, why aren't you working well? Release more hormone, release more hormone. And so you see very high levels of TSH with that low T3, T4. When someone has an eating disorder and they are malnourished, the metabolism will naturally want to slow down. And the thyroid is the driver of the metabolism in our body. And so what we see is something that looks like a low T3 and or T4, meaning the thyroid is not producing enough hormone. And you would expect to see a high TSH, but you actually see a perfectly normal TSH. The body's like, woo, I like this. I like a low metabolism. I don't want to be expending extra energy. I'm going to keep things low and slow so that I can save as much energy as possible. You might feel cold a lot, might feel kind of constipated, might lead to fatigue. There's all kinds of symptoms that can come along with it. But what you don't need in those moments is a thyroid medication. What you need is nourishment. And with consistent nourishment, if you recheck that thyroid in maybe 6 weeks, what you will often see is that with that nourishment, the thyroid starts to function perfectly normally again. On the flip side of that, when somebody starts to eat again and to recover, and the brain and body start to trust it again, it may say, oh my gosh, I'm so thankful that you are feeding me again. I want to rev up my metabolism. And we will not necessarily see it in the thyroid, but we see something called hypermetabolism, which is when everything starts to rev up in the body. And one of the ways that it manifests itself is through a tremendous amount of sweating. So we will have clients who will say, I wake up in the middle of the night with night sweats all the time. And it's because their body is creating extra energy simply because it can, because now it knows, I'm going to be nourished. And it says, I can create extra heat. And then we have this beautiful mechanism in our body so that we don't get a fever, and it's called sweating. And so you see people who are in that recovery process who end up sweating a lot with this very high metabolism, needing very high meal plans in order to maintain their weight. And what we see is that with time, it will normalize, but what we don't know is when that's going to happen. The other thing that we see very often is we see changes in sex hormones. So if we're talking about a man, we would see decreased levels of testosterone. In a woman, you would see extremely low levels of estrogen and progesterone. And what you end up seeing is what would end up looking like an involuted ovaries and uterus that would look either prepubescent or postmenopausal. They shrink and they get smaller, and those hormones stop being produced. Essentially, it's like the body's way of saying, if you are not nourishing me properly, I know how much energy it takes to create a life, and you don't have that energy right now, and that entire system shuts down. And one of the ways that that ends up being manifested is through something called amenorrhea, which is when the body stops producing a natural period. One of the things that used to happen frequently, I don't see it as much anymore, but that we used to see a lot, was that when somebody stopped getting their period, they would be put on an oral contraceptive, on a birth control pill, because the thought was, then you'll get a period and that will protect your bones. And we'll get into bones in just a second. But what was found is that it's actually not protective at all, that what somebody needs is nourishment and consistent nutrition. And once somebody has that consistent nutrition for anywhere from a month to a year, you will see that that hormone cycle resumes itself, and that somebody will often start to get their period again. It used to be that amenorrhea was part of the diagnostic criteria for anorexia nervosa, and it's no longer part of that criteria because there is so much variability to when or if somebody gets or doesn't get their period. But what we have seen is that whether someone gets their period or not, If they are malnourished, which we know is true universally with all eating disorders, there is a risk associated with that malnourishment. And one of the biggest risks that we see with it is in the bones. We know that bones are affected by eating disorders, but the problem is we don't know when they will be affected by the eating disorder. So throughout life, we are constantly creating bone. And fun fact, every 10 years, we have an entirely new skeleton because we want our bones to always be fresh. So throughout our life, we are depositing bone and we are recalling bone. And the ratio of that deposition to recalling changes throughout the lifetime. In puberty, we are at the highest bone deposition rate that we will have. So we are just depositing bone, depositing bone, depositing bone. We're still recalling, but it's just a little bit because we want our bones to be big and thick and strong. Somewhere between 25 and 30 years old, we don't know when, everybody's body is different, we reach a state of equality. So we're depositing bone and we're recalling bone in equal amounts. Our bones are their biggest, thickest, and strongest. For women, postmenopausally, very often what happens because those hormones are gone is women end up recalling more bone than they're depositing, and their bones end up becoming weaker. When someone has an eating disorder and those hormones are affected, bones become weaker. And so one of the things that we do is we check what's called a DEXA scan or a bone density scan to measure and see how thick are these bones. And it's always measured on a normal bell curve. And you get your results and you're going to say, okay, I have a score of a 0. A score of a 0 means you have 100% of expected bone density. Anything between +1 and -1 is considered normal. 90% of people fall within that normal range of bone density. Once you get below that marker of -1, so anywhere from -1 to -2.5, you are classified as having something called osteopenia, which means you have some bone loss, but it may not be irreversible. Once you have a score of -2.5 or below, that's considered osteoporosis, which had always been considered irreversible bone loss. And what we know is that bone loss happens with eating disorders. 30% of people with anorexia have osteoporosis and 90% have some bone loss. And we see bone loss in all types of eating disorders, not just anorexia. When someone is young, so most of the studies that had been done on postmenopausal women. And once you are in that postmenopausal phase and you have lost a significant amount of bone, it's going to be very hard to make up any of that bone loss that happened unless you take medication for it. What we are seeing, though, is that in the younger population, we see bones affected in the same way, but because somebody is so young, if they are able to recover, there is time left to make up some of what was lost. And so we will see people who will have a bone density scan that says you have a significant amount of bone loss. And then they'll have it rechecked in 2 years and it will show much less bone loss because they have made up some of what had been lost. So it had been considered one of those irreversible pieces of an eating disorder, and where we won't anymore say that it's totally irreversible, it is one of the pieces that is the hardest to make up. And it's important to think about this because when it comes to eating disorders, there's often a lot of movement involved in an eating disorder. And if somebody has bone loss, we are sometimes having life-changing conversations with that person. Because if that bone loss is significant and they were an athlete, let's say that this is somebody who is a runner, we are now going to be having a conversation that it's not safe for you to run ever again. if you were a skier, we may be saying, well, you can ski, but you sure can't fall, because if you fall, you may break a bone. When I worked in a hospital, I worked on an orthopedics floor, and I would have some little old ladies who would come in with a hip fracture. And one of the things that I would always ask them is, so did you fall and break your hip, or did your hip break and then you fell? And most of the time it was, you're right, I was just standing there, and then all of a sudden I was on the ground. So it wasn't that they fell and broke their hip broke and then they fell. And that is a direct result of osteoporosis. And when we're talking to our younger patient population, that's the kind of conversation that we're having to have, is that they are at increased risk for spontaneous fracture. And the key to it, recovery. So I guess my closing message for today is that, yes, there are a tremendous number of complications that can happen from eating disorders. Most of them are reversible, or at least partially reversible. But the key to it is that it takes consistent nutrition and recovery from the eating disorder. So, we can talk about a vitamin or a supplement or something that you can take, but at the end of the day, if you're not recovering from your eating disorder and nourishing your body, you're not going to experience the full effects of recovery that could happen if you focus on that recovery. So I don't know if there are any questions that anybody has from anything that I shared today.
We do have a question in the chat, and if anybody else would like to ask a question, just feel free to send them in the chat and I will read them to Chrissy. But Shannon would like to know, with the recent political events limiting reproductive freedoms, I found that many of my patients have IUDs and as such don't get their periods, which gives them one less bodily process to monitor as they recover. Do you have any suggestions for an alternative benchmark in this case? Is it advisable for folks to get IUDs when they are in an acute recovery phase from an eating disorder and have an amenorrhea? I hope I said the right history.
Shannon, that's a wonderful question. And I do see it all the time. I see clients left and right who are coming in who have IUDs. And that is something that if it's a hormonal IUD, very often they're not going to get their period at all. And I think that there's a couple of ways that we can navigate it. One of the questions that I will ask people when they come in saying that they either have an IUD or they take birth control is, are you taking it for birth control reasons? Because one of the things that we've seen is that when somebody is going to get their period back, they will ovulate before they get their period. And there have been times where we've had clients who never got their period because they ovulated, then they ended up pregnant. So if that's something that they're not wanting, then I wouldn't recommend them having that IUD taken out. But there are other things that we can look at. So if it's somebody who maybe knows their history prior to an eating disorder and prior to getting the IUD put in, typically they may know that weight that they were at where they got their period, and that would be one of the benchmarks that we would be shooting for. But we definitely want to make sure that if somebody is taking birth control for birth control reasons, that we don't limit that or take that away. But if they're using it for, let's say, their skin, or because a doctor told them that they should take it because it would protect their bones, then we'll often say, what would happen if you stopped it? And is that something that you would be willing to try?
Great. We also have a question from Alexis. How do we talk to clients about these things in a way that is therapeutic and not fear or shame-based?
Mm-hmm. So I talk to my clients about this kind of thing all day, every day. I try to be very factual with it. I'm never trying to do anything that's going to cause shame for them. I don't want them to feel shame, and I don't want them to feel guilt about something that, they feel enough guilt about having an eating disorder to begin with. So one of the things that I always try to do is frame it in a way that says, your body may be compromised, and here are ways that it can recover. Here are ways that it can start to feel better. Often I will also not have there are times when I will have a conversation with someone when they are compromised, but often when someone is very compromised, cognitively, it's going to be harder for them to retain the information anyway. And so we can have more conversations about it later in their recovery, when we can talk about something like, did you feel dizzy a lot, or did you feel tired a lot? And they're like, wow, I really didn't even realize how tired I was all the time. And you can help them to see retrospectively what they might not want to go back to, and use it as fuel to continue in their recovery.
Lacey would like to know, we know that facts about negative effects aren't always enough to spur change, but what information about health effects do you feel has been the most effective?
Typically, one of the most impactful pieces of kind of these medical complications is for women, reproductive, and for kind of universally talking about the bones, because people know that that's one of those pieces that is less reversible than others. But a lot of clients that we have that come in, and again, we're not talking about it in a negative way, like, see, this is a complication that your body has because of your eating disorder, but more we're talking about it in terms of reproductive. A lot of people want to know, have I done permanent damage to my body? Am I ever going to be able to have kids? And what we know is that with recovery, we've seen it often happen, that there are no long-term reproductive complications as a result of an eating disorder. It does take recovery and it takes hard work, but it can be fully reversed. And so a lot of what we try to do is to talk about it in a positive way as a motivator, rather than a negative, like, see what you've done to your body kind of thing. They already feel plenty of guilt about it. We don't need to add fuel to that fire.
Thank you. Scout would like to know, do DEXA scans interpretations change with age? For example, -2.0 meaning something different for a teenager versus someone closer to middle age.
Yes. So there are differences in interpretation of DEXA scans, especially with a younger population, because there's so much more variability, and it depends more on whether or not somebody has gone through puberty, where they are in that process. So when someone is typically it's over the age of 20, that may have shifted just a little bit now. They are measured against a population of 30-year-old women. When they are younger than that, they are age and gender matched. And there is not actually a diagnosis of osteopenia or osteoporosis for someone who is younger, because there is so much time to make up for what has lost. And so what you'll find is that there is now an interpretation that may say something like less than expected bone density. But if somebody has less than expected bone density, what we know is that with an eating disorder, that means their bones have been compromised. And we want them to know that A, that can have implications in terms of movement, and B, that they have time to make up some of that bone loss that may have happened.
Great, thank you. And I have one more question. I've got one more question for you, Chrissy. Allie wants to know, could you talk a little bit about the effects of chronic dehydration for clients with restrictive eating disorders?
Yeah, so with chronic dehydration, you're going to see a lot of different things. So when we talk about lab values, there are a lot of different ways that you can see some chronic dehydration happen. You can look at BUN and creatinine, which are kidney function tests, and you may see those mildly elevated. You don't want to see mildly elevated kidney function tests. It means your kidneys are not working as they should. With restoration and appropriate hydration, you can see it reverse itself most of the time, but there are some examples where there has been some chronic kidney damage that has happened. One of the other things that we see when somebody has chronic dehydration is that there are hormone shifts in their body. One of those hormones is something called aldosterone. So aldosterone is a hormone that's released from our kidneys that actually will tell our body to retain fluid. And it does that because we are dehydrated, and it doesn't want us to lose that precious fluid that we have. What happens though is that aldosterone telling our body to retain fluid doesn't shut off right away when we start to drink enough fluid. So we actually often see a complication that happens with that when somebody starts in that recovery process and starts hydrating appropriately. And one of the things that we can see is actually full body swelling sometimes. So they're now drinking enough fluid and they're retaining all of it because the body is still saying, retain this fluid, retain this fluid. And that can be an incredibly uncomfortable feeling for somebody who is going through that recovery process. And you'll often hear it referred to as fluid shifting. So that fluid is not being excreted through the kidneys and through urine anymore. It's being held onto and retained, and it can actually sometimes happen so much so that it goes out of our vascular system, out of the veins and arteries, and into the tissue in our bodies that can cause a lot of swelling. It can be painful, and it can be very traumatic for someone with an eating disorder to watch happen to their body, because there can be enormous weight shifts that can happen very, very quickly. Sometimes you can see 10 to 12 pounds of weight shifting in a matter of days when somebody is retaining a lot of fluid. What we do know is that it will resolve with time, but it can take a few weeks for that to happen.
All right, Chrissy, I have one more question for you. I know we're just about out of time, and I apologize because there is a 99.9% chance I'm gonna mispronounce this word. But Kenna wants to know, is rhabdomyolysis common in eating disorders when someone exercises moderately each day? I'm sure I didn't say that right.
Yes. It is something that we can see in eating disorders. It's something that you can see from, so remember that phosphorus level that we talked about way back at the beginning, and that phosphorus levels in our body can be depleted. That can lead to that ineffective muscle contraction. And rhabdomyolysis is a complication that can happen as a result of that, where the muscle basically starts to break itself down. It cannot tolerate the intense movement. So it can happen to someone who doesn't exercise and then all of a sudden does something really intense with exercise. It can happen also to somebody who is not moving, but who ends up having that effect as a part of refeeding syndrome, where maybe it doesn't affect their heart the way that it can with the congestive heart failure, but that lack of phosphorus with the increase in nutrition can end up leading to rhabdomyolysis also.
Great, thank you so much. Unfortunately, that is about all the time that we have for today, but I want to thank everybody for being here. And Chrissy, thank you again so much. This was such an amazing, informative presentation you gave, and we're so grateful for you.
Well, thank you so much for having me.
Everybody, enjoy the rest of your day, and we look forward to seeing you in the next session.
Thank you, Chrissy.
Bye.
Bye.